We will have a debate on gut decontamination together with Marcel van den Brink from New York, from the Sloan Kettering Cancer Center. And we both are working on the role of microbiota in stem cell transplantation since many years and are cooperating on that topic. Now, if we talk about decontamination, then this has been widely used over decades. And this goes back to the very old observation of Van Beckom in the 1974. He had shown that mice grown under germ-free conditions, that means mice having no gut microbiota, have a much better survival in GvH models. And since that time, there was a hypothesis complete decontamination could protect from GvHD. And these experiments were later on repeated in larger animals, including dogs and monkeys, and then translated to the clinics, especially in the Netherlands, but also in other centers. And they Fossen, for instance, showed even in 2014 that children receiving complete decontamination had a low incidence of GvHD, although one has to admit children anyway have a low incidence. So this was one argument to use decontamination in stem cell transplantation, and the other argument is simply gram-negative infections from during neutropenia. We know from hematology and from many studies that prophylactic antibiotics can reduce neutropenic infections and septicemia, and this was an other argument because bone marrow transplant patients are also septicemic, and for that, decontamination and prophylactic antibiotics are widely used throughout the transplant community. There's a survey of the EBMT in 2020, and this survey shows that about 57% of centers are using some kind of antibiotic prophylaxis and decontamination. Now, on the other hand, Marcel's studies and our studies since 2012 showed that in patients, we rarely achieve decontamination. What we see in patients is that the vast majority of microbiota is lost during decontamination, during prophylactic antibiotics, and during therapeutic application of therapeutic antibiotics. And it turned out that this so-called dysbiosis, which eliminates almost all protective commensal bacteria, is the worst situation for patients. So in several single-center studies, it was shown that dysbiosis early after transplantation, loss of commensal bacteria, is associated with an increase of gastrointestinal graft-versus-host disease, with increased inflammation, and even with poorer outcome. We even had the chance, together with the New York group and others, to participate in a multi-center trial where we compared gut microbiota in 4 centers across the world, and in all centers we found this unique pattern. Patients with dysbiosis had a poor outcome. So we have two opposing observations. On one hand, it's protective if we get the animals and maybe the patients germ-free. On the other side, we do not achieve a germ-free situation, and we then have dysbiosis, and this is worse. Now, one could ask whether decontamination is still protecting animals in the area of new methods to assess gut microbiota. In former times, it was only bacterial cultivation, but nowadays we do it via 16S sequencing, which is much more precise and detects a lot of bacteria which cannot be cultured. There are two recent murine experiments applying prophylactic antibiotics in GvH models, and these experiments showed that they could reduce the gut bacteria almost to 10 to the 1, so which is close to germ-free situation. And in this situation, you still see protection of animals from lethal GvHD. So if we could achieve complete decontamination, there should be protection, but we do not achieve it in reality. This could be one explanation, but in our research also showed that we have differential effects of antibiotics. On one side, prophylactic antibiotics reduce commensal bacteria and induce dysbiosis on the long run. On the other hand, there's another mechanism in the gut which is important for graft-versus-host disease, and this is translocation of bacteria from the stool and from the gut lumen to the cell wall, to the tissues. And it has been shown by the group of Robert Zeiser, but also by the group of Andreas Beilhag recently, if we can reduce translocation, we have less neutrophils and less inflammation and GvH-inducing cells in the cell wall. So we have opposing effects. On one hand, long-term antibiotics induce dysbiosis, make GvH worse, and short-term effects on translocation are protective. So that's the main reason, in our opinion, that we cannot solve this issue in the moment, and we need very intelligent approaches in the future to modulate microbiota. One aspect could be to leave the systemic action of antibiotics, but to neutralize antibiotics in the gastrointestinal tract to maintain commensal bacteria. There are clinical trials on the way, but for the moment, it's better not to have dysbiosis, and in my view, to avoid too much decontamination. But of course, you have to be very fast and quickly to introduce antibiotics if the patient needs them.